Good evening, dear friends. Welcome to AIG. My name is Mohan Ramchandani, and I am with Dr. Zahir, who is Senior Consultant at Asian Institute of Gastroenterology. Every Tuesday, we bring to you an eminent international speaker who speaks to us about the COVID situation in their country and how this COVID situation has affected our gastroenterology practice, and how the gastroenterologists are coping up with this new situation. So this week we have eminent speaker from Cairo, Egypt. He is Dr. Mostafa, and Dr. Zahir will introduce to him, and then we'll listen to him.
So Dr. Mostafa Ibrahim, he needs no introduction. He's a renowned figure in the field of gastroenterology and hepatology. Currently, he is the professor in Gastroenterology Hepatology at Theodor Bilharz Research Institute, Giza, Egypt. And he is an international committee chair at the prestigious AIG, and he is the president-elect of Pan-Arab Liver Transplant Society. I welcome Professor Mostafa Ibrahim to share his experiences of COVID-19 situation from his place. Dr. Mostafa Ibrahim.
First of all, thank you very much for such a really prestigious invitation. Thank you, Dr. Moana, and both of you. And really, it's I'm proud, and it's really a prestigious invitation for anyone over the world to speak in AIG webinars and educational activities. So I will share now my slides. Yes. So I have asked to discuss about COVID-19 in Egypt and how we as gastroenterologists and endoscopists had what we have done during the last months. So first of all, before I start, I have two thank you to say. So the first very special thanks to Professor Mohammed Hassani. He's the Egyptian COVID unit director. He's a consultant of hepatology. And he had been managing all of this COVID all over the country. And when I asked him a few days ago to share some of the official slides and official figures, he shared with me. So part of my presentation will be some of our what happened on governmental aspect in the COVID unit. The second thank you is to my hospital, to where I now practice more is the Masri International Hospital, where I take care of the endoscopy units for the last 3 years. So my presentation will be 3 parts. First of all, overview of what happened in COVID all over Egypt. Then how this impacted the GI practice from my point of view, and I will take my unit as an example. On the other side, how we have this as an opportunity. So in Egypt, when the story started a couple of months ago, I think the reaction this time of our government and the Ministry of Health and our COVID unit director was really fast. So from day 0, we have created a call center for all COVID patients that we can call and to be diagnosed and to be referred. This call center was a 24/7 hours call center with 500 agents taking calls from all over Egypt. And then communication-wise, this time also Egypt did a great work in having, we have 3 main channels of communication. So social media, we have a daily report on social media and including advices to the patient. We have an official WhatsApp, business WhatsApp, which can give the patient answers and even give them some advices. And we have they launched an official app for the COVID within the last 2 months. So in Egypt, we have 2 different types of hospitals. So we have 320 triage hospital that the suspected patient will go and be assessed, and it's covering all over the country. They will take the swab, and then we will see it either they need temporary isolation or to be sent to one of the isolation hospitals. Then, with the help of from the Ministry of Health as well as the help of Egyptian Army, we have built one of the biggest field hospitals in the Middle East with 4,000 beds and 40 ICUs and 14 ventilators. This is already happening, and this has been built in the last months. Testing facility, during the last 3 months, we have been doing 30,000 tests per day. All over, which is connected to a database to all over the country. And again, this is not my work. This is really the MOH work, and directed by the government and by Prime Minister and our Ministry of Health, as well as Dr. Hassani, the COVID unit director. Ambulance, really, they did great work. Even personally, I was not expecting such work. So we have 1,500 vehicles that they were running all over the country for the last 3 months, taking patients from home to the isolation or changing patients from isolation to the rehabilitation center all over the country. We have 24 public governmental hospitals. And also the thing which Egypt had done differently, that we used also the hostels and the hotels to be for the patient, for mild patient to be isolated there. This is a picture of one of my friends doing delivery for a patient inside one of these hospitals. Then the other thing, in Egypt, they did really great work in tracking patients. So we have more than 1 million patients tracked in different villages and different cities, they are the patient that they have been in contact with positive patients. And this is also one of the things that I'm really proud that our MOH did, that they have this treatment kits for very mild patient. When the patient is diagnosed to be positive, he will go to one of the hospitals, he will take the medication, he will go home, and all what I have said is free of charge to any Egyptian. Regarding guidelines, we have published different guidelines for COVID management for the public and as well as for doctors. Clinical trials in Africa, we have the biggest number of registered clinical trial, ongoing trial now. We have 69 registered clinical trial. Some of them also with global trials for the vaccination, as well as also the plasma trial that we are now doing, also taking plasma for patients that they have been already treated and doing this and donating this plasma to critically ill patients. Also, locally, we are now manufacture 2 new drugs. One of them is Gilead voluntary give the license for remdesivir, and also we are locally manufacture the favipiravir. So this is the graph which we see. You don't need this. So this is online. This is the graph of the daily patients that's there every day. And this is our R. So in just a couple of days ago, we reached now the R of 1. Meaning only one patient is infecting one. We have started 3 months ago of R 2.5. So this is just an introduction about what the government did on all over Egypt. Then the next part of the slides, what this really COVID impacted our practice. So in my unit, we have 12 endoscopy consultants, 6 endoscopy specialists, and 8 nurses and 4 admin assistants. We are nothing compared to AIG, I can understand, but if you can see this, for example, from the consultants, we have only 4 consultants still coming to the hospital doing endoscopy. We have some consultants, either they are obliged to stay at home, or they are infected, or they are, I would say, afraid to work in such conditions. So this is one of the things that we have a big defect on I would say, high-level therapeutic endoscopists. Regarding cases, this is the average of our work in this unit in 2019. So our patient clinic, we see per month around 1,500 to 1,600 patients, of a total of 350 endoscopies per month on average. And this is what happened. So the first curve is that the first bar in each part is the 2019 average. So we have a 200, for example, for upper endoscopy in general doing, we have from 200, we came down, this is April, May, and June. So now we are doing per month less than 40 patients per month. Same for colonoscopy, and even more for ERCP. This is the biggest defect, which I can explain this, but the patient coming to do, let's say, a patient to do upper endoscopy for gastritis or for reflux, or to do follow-up of band ligation, patients themselves, they are afraid to come to the hospital, and they wait till the pandemic will be over. This is a very interesting slide where we have a huge decline in the consultation number. So we were having per month, this is a per month consultation number. We usually have this number, which is between 1,500 to 1,600. Now we have less than 300 patients per month on the outpatient consultation in the GI specialty. But what happened, which is also for me was really a new thing to do, is the virtual consultation. So from scratch, 3 months ago in Egypt, nobody knows anything about doing a virtual online consultation. Now we have, in June, we have 200 patients have been consulted via one of the virtual tools. This is another example, for example, of my last Sunday calendar. So you can see here, normally this is the patient that they will come to the clinic. But you see Zoom, 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 Zoom. So more than 50% of my consultation patients prefer, when they call the call center, they prefer to do it online and not to come to the hospital or to the clinics. Nowadays, this is one of the very popular apps in Egypt named Doctor Online, where you have the patient will have an app and you will have an app, and they start having the consultation and follow up via their mobile phone. So this now, we have a lot of platforms in Egypt nowadays doing this. This is two examples of working. I have worked in AIG. I remember in last August, I have never put a mask during the last 15 years when I'm doing endoscopy. But this is how I work now, which is also very challenging. So it's not only, we all know the importance of PPE and to put, but this is really to do a difficult ERCP or to do a difficult EOS biliary drainage or anything, and to be dressed like this is really challenging. But this is another picture of one of my fellows doing upper endoscopy and also putting PPE. This is another open question. So because Egypt it's a poor country finally, I don't think that we can now, I don't know for how long we can withstand doing and buying and putting all of this PPE, because finally this is an extra charge for all of us. This is another example when I did ERCP, the first ERCP inside the COVID ICU. This was really, we have to move, because this was the first step. We don't have a dedicated place to do, but I have a patient in the ICU that he came with cholangitis and COVID, and we have to move to the ICU with the fluoroscopy and with all the endoscopy tower, and we did inside. And another example from also one of my colleagues doing dialysis inside the COVID ICU. So in my hospital, they took 2 steps. Step number 1, and this was end of March, April till mid-May, that we only have the dedicated ICU and dedicated ER room and pathway where the COVID patient will come. First of all diagnosed, and then they will go either to the ICU, or if they are moderate patient, they will go to an inpatient dedicated section. But the management of the hospital, they discussed and what will be the future, because we know it will not finish tomorrow morning. And we will start having normal patients, like as a patient with bleeding ulcer coming with COVID. We will have patient having acute cholecystitis and COVID. We will have a female patient that she would like to deliver and she's a COVID positive. This is why this was the second step. The hospital decided to have a dedicated building which is a COVID building where we have everything. So we are starting from the outpatient clinic to the also for COVID, for diagnosis and seeing COVID patient, as well as specialized clinic. Where this is the different new part that we have now specialized clinics, gastroenterology, nephrology, cardiology, chest for COVID patients, and this place is equipped with an operating room, endoscopy tower, dialysis, and rehabilitation unit. And this will open for us also a new question: should we continue like this or not? I will summarize this in my last slide, but again, this is an open question to all the hospitals. Should we have a dedicated area? Should we have a dedicated building? What we should do in the near future? On the other side, so this is with the negative part, where we have a lot of COVID patients, less endoscopy, less advanced procedure, less staff, less experienced endoscopists. On the other side, because I manage the training center, the educational part, the Roya Training Center. This was an opportunity for us. So COVID was an opportunity for us. Normally, this is how we educate people. Exactly what I did in the AIG lab last summer, where you train doctors. You go. This was in Africa on the left side. The right side is one place in Europe, where we have group of doctors and our simulator, and then we start training them. We have done in the last 4 years 140 courses like this. But in COVID area, this is impossible. In COVID time or COVID pandemic, this is impossible. This is why exactly what I'm doing with AIG today. We thought about, why not? We should continue our message in educating people. And this is where this international virtual education started. This was the first wave. This was in April and May. And you can see the figures starting from Professor Ibrahim, Mostafa, my father, going to Giovanini, and we were proud to have Professor Reddy, one of our speakers, Professor Vivier. This was the first wave. And we had a very, very good vibes and very, very good positive feedback. This is why we went to the second step, having the second wave during June. And this was also, you can see the figure here, Professor Yamamoto, and we have Evo, my friend, and we have Professor Saito, Professor Osman. So the same, people giving very, very good of educational content virtually, and we have a very good positive feedback and also a lot of attendees on the virtual online. Then we thought, why not? Why not to take it to the second part? And we did 2 live endoscopy workshops during the COVID period. The first one was on the 16th of May, and then the second one on the 13th of June. And both of them I have been supported by my friend, Professor Hani Shahab, where we did live endoscopy from the hospital, broadcasted also online. Just I will show you, this is a very important figure we all need to think about. So this is Hani was performing a live case of spyglass, and just few days after this was broadcasted online, exactly like what we are doing now. After a few days, we had more than 4,000 views to the case. So if we think from the positive part, if we were educating people in a small room and just broadcasting a live case from the hospital to this room, it will maximum in Egypt. Normally it will accommodate 300, 400 doctors, 500 maximum. But on the other side, using now the virtual live and the internet and this virtual platforms, we have been able to reach this number of doctors and to train this number of doctors. So to summarize, I think I tried to show you the reality, what's happened in Egypt and Middle East. But we have a lot of questions, I think. Should we really, not only Egypt, all of us, should we invest more in this virtual consultation? Is it correct? Is it not correct? Maybe it's easy for the patient, but again, this is a very big question. We need all to think about: should we all go to this direction? But on the other side, we will have still the clinical part is important. Can the internet and this online virtual tool really help? Other thing, virtual education. We can see now, and we can from everywhere, that virtual education is the thing happening everywhere now, exactly like what I'm doing now. But on the other side, we as doctors, when we go to the congresses, it's not only just to go to the lecture. There is the human nature and networking and having good dinner and going for shopping and by night having good discussion with friends. All of these things, I don't know. So personally, yeah, maybe we can have good science, good education, but we are also missing a big part of our daily, I would say, networking and social professional life. Then the other question, which is a big other question: should we really put more PPE or less PPE? I can see guidelines and white papers published every day, but personally, I don't see anything solid. So we have doctors and friends that they have been in full PPE and they are infected, and we have people having less PPE and still not infected. So again, I respect the guideline, I respect what the WHO said, and I respect what CDC is saying. But on the other side, this is a very big question, because there is a big financial strain, especially on countries like in India or like in Egypt, that we are not a rich country. And even rich countries, the US and Europe, they have also till date have a big lack of PPE. So this is another question that we need to investigate and really to do a true research. And should we do more PPE or less PPE? Finally, the question, which is, I think, no answer till date. Should we really, when we have a patient, I'll give you my last story. So I have a patient 2 days ago coming with gastritis, reflux, severe epigastric pain, and he's a COVID patient. He's a COVID positive patient. And when I asked him why you are coming to the clinic now, you are a COVID positive patient, you should be isolated at home and you should not come, you can call us or something. He said, doctor, I need to see you, I'm in pain and I need to see you. So what should be the strategy? Should we hide from this patient, or should we really treat this patient and to be ready for this patient? I think this is the open question that we need all of us to think and to see how the next maybe 6 months or 1 year is coming, because I can see a lot of mild COVID patients everywhere, and they start having other symptoms. What we should do with all of this patient. So by this slide, I came to my last slide, and I'll be ready for any question and discussion. Thank you very much.
Thank you, Dr. Mostafa. It was an excellent lecture, and you just gave us a broad perspective of how the government has controlled the corona spread in Egypt, and it was heartening to see the R coming to 1 very quickly in 3 months, and we are still it's very big lessons from you to learn. It was also heartening to see how you have managed in your hospital a separate COVID section where patients comes to you with different issues like dialysis or requiring GI bleed to be received in the hospital, and the triage facilities, they are absolutely fantastic. So you are an eminent personality now, and you are chair of international committee in ASGE. So where do you think the future lies? What should be the protocol adopted by various endoscopy units to receive the patients, and how to bring these, though we have many guidelines saying that okay, this patient is having emergency endoscopy requirement, you straight away get him in and do with adequate PPE. And now we are seeing very much many difficulties wearing this PPE day in day out. It's like very cumbersome, and it cannot be now taken for routine for long time. So where do you think the future lies? How should we, adapt to this new situation?
Thank you very much for the question. I think this is the $1 million question. It's the very difficult one to answer. But personally, it's a very personal feeling or personal opinion. I have read all the guidelines. I know that, okay, the guidelines said that if you have an elective patient, postpone it, and you have an emergency patient, do it with full PPE. But on the other side, this is not on the ground, and in reality, this is not happening. We have patients coming to our units, and they have simply a polyp to remove, and you would like to remove it, and they don't want to wait for another 6 months or 3 months. So I think we should work. We should now the figures globally, not only me. And if you see the political part of it, even on political part all over the globe, they decided to open and to continue, and everyone to work with taking care and with putting the precautions. And I think we as doctors, we should work. We should continue working. We should treat our patients whatsoever they are coming for. We should treat the patient like before. On the other side, how to protect ourselves from doing a colonoscopy or an upper endoscopy for a COVID positive patient. Personally, I see putting all of these PPEs, changing. I have a nurse that she will shout to me, Mustafa, don't enter the room. You didn't put the second glove. And I can understand all of this, and I respect the guidelines. I do it, but this is very difficult to be done on every day. I give you a very funny story. Even putting the N95. So now I put my N95 before I enter the hospital. I keep putting it till I leave the hospital. But this is non-human, because you don't drink and you don't eat and you don't even respirate for 8 hours. So this is difficult. We cannot live like this for the next year. And literature-wise, really the guidelines till now, I think they are too much protective. They are protecting us, and the societies and big societies, they are conservative. But on the other side, we need to see more and more figures assessing, really, is it that dangerous? Is it really, if I put only the mask without the goggles and without the 3 gloves and without all of this, is enough or not? Should I really, if I can put, if I can do an upper endoscopy or ERCP, if it's a short procedure, if it's a long procedure? I think there is a lot of questions that my feeling that now guidelines and now societies are very conservative, and they would like to be in the safe side, so they put the maximum protection. I can see the future. Yes, we will still have putting masks, but I don't see this full PPE. It's happening every day because it's technically impossible, financially impossible. But also I can see the patient will start coming again, doing the normal procedures everywhere. The only thing, which is my advice even to my fellows, we need to, number one, treat the patient, because having a COVID patient who is bleeding, we should not really hide from him, we should treat him. So my advice to my friends and fellows, we should treat them, protect ourselves, and we should treat them, and we should not wait, because patient will die from bleeding and will not die from COVID.
Yes, I agree.
Yeah. So we agree with you, Professor Mostafa. And what do you think? What about trainees at your place? And are they dissatisfied? Are they actively involved in do they get endoscopies? Do they get to do ERCPs? Because at this point of time, there's a lot of pressure that you should finish off the procedure quickly. So what about their endoscopy training at this point of time at your place?
This is another very, very important question. So no, what we are doing, I always do the procedure myself now, because I need to do it fast and not to teach anyone. This is what's happening now. But and again, all the hands-on training that we have been doing, like in your lab in Roya in Egypt, all of this hands-on simulating thing stopped for the time being. So there is a big defect for the trainees, from the perspective of the trainees, for the training. either on hands-on or in live cases. So all of this they stop. The problem in this is very also political. So if when I ask my trainees and my fellows, you would love to do a hands-on training session tomorrow, and we do for you one of the simulation, they would love to. But the problem, if you go to the management now of the hospitals and the industry, they are afraid. They say, no, we will never now sponsor or support any educational event face-to-face. So this is a dilemma which we are inside. We have the need of the trainees to continue, and we have the need that they see, okay, virtual education is good, but not enough. They need to come back and to do again, to touch the scope and to start the training again. But on the other side, management everywhere and the leadership everywhere, they are afraid to open this. So I can see a big defect in this. I know that virtual education is nice, but I personally, I don't feel that it can substitute true mentorship or mentor-mentees relationship, where you have your mentor beside you, teaching you step by step what to do and supporting you. This is virtual education can never change this.
Yes. It was very nice to see that Egypt is also producing the drugs indigenously, and I saw Favipiravir and Remdesivir. Do you think vaccine is, we are seeing any future, the vaccine coming up, and do you think the vaccine is the only hope for us as of now?
This is another big political question, but I see vaccines coming end of this year, but two big questions, which is I don't have the answers. Are they really effective or not? This is question number one. And they will be available or not. So, because you need, theoretically, you need to vaccinate 8 billion individuals on Earth in a couple of months, which is technically impossible. So, who should be vaccinated? This is a big question. And it will be available to who and which country and which region. And then effectiveness. I think this is, we will see some vaccines coming end of this year, but I don't think that the story will stop when the vaccine, because there is another question about even mutation of the virus, effectiveness of this vaccine, like before, like H1N1, H1N5, they have changed it, and every year the vaccine will be updated and will be changed. So there will be vaccine. I personally, my personal dream will be to have the vaccine, to give it to the people, to the old age people. This is number one, to protect them. And I would love all the government to do this. So we vaccinate older people to be able to save them, and then we less vaccinate younger people. I think this if I'm the decision making, I will do this.
Okay. So, Professor Mostafa, there's one more question that I had in my mind, that gradually we are opening up routine endoscopies because we have a big backlog, and because it's a tough deal to crack, because subsequent as you move on and you keep on postponing these cases, there is a big backlog that you have to deal with later on. So how's it there in Egypt at your place? Have you started clearing that backlog, or are you still doing selective cases, or do you think this is not the right time that you should start doing routine endoscopies there?
Okay. I think, thank you again for the question. I think we didn't start yet to call the patient that they are doing for regular follow-up. Let's say patients that are coming for regular changing of a stent, biliary stent, or patient coming for regular screening, colonoscopy. All of this we didn't start. We are only doing now the patient that they come to the hospital with an indication for endoscopy. However, I see it will open, because we are simply, as doctors, we are not the only industry that it didn't open. Because if you can check everything, every other thing in Egypt, From last Saturday, everything is open. So shopping malls are open, supermarkets are open, industry, factories, everything is open. So I think the second step that we will open. So we will open to everyone. The only problem in open is two things that I think we need to think that it will never happen. It will never be like before, which means the waiting area of this huge waiting area in the AIG in the ground floor, it will never be like this. Yes. The idea that it will be, I think, for example, I know that you already have done this, that it will be more digital, that people should have receive a SMS before they come and then they enter the hospital in the specific timing. So management will change, this is sure. We will have less waiting area, less family of the patient coming with him, all of this, but we should work because other industries, they have already started to work. So I think we should work because our type of work is we are saving patient life. So because my personal perspective in this, which I have said it everywhere, patient will die more with MI, with bleeding ulcer, with stroke, more than patient will patient will die from COVID. So I think we should open, we should work by maybe new guidelines and new management style. On the other side, we should also, as doctors, we know, this is why when I told my fellows very straight, we should protect ourselves, full PPE till now, but on the other side, I know that we will be infected somehow. Every day, one of us will be infected. So we should not panic. And this is my final message. We should not panic. We as younger age people, doctors, we know that we are in high risk. We will be infected sooner or later. And most of the patients, like in Egypt now, most of the patients now, they are mild patients. So the idea that we need to protect ourselves, but if we are infected, we should not panic. It's all about taking care of ourselves, and then we continue. We all should continue.
Yeah, we fully agree with you, Dr. Mostafa. With the want of time, I think we should end our discussion here. And it was fantastic to have you with us. And thank you very much for sparing your time with us. Thank you so much.
Thank you very much. Thank you. Thank you. And my best regards to all AIG team. Thank you very much.
Thank you.
Bye.
Bye-bye.